I must thank Jain sir, Alok Kanungo sir, and Professor A.K. Das sir for giving this opportunity. So, as rightly said by Jain sir, that FDC is the norm now, and it adds to the, it simplifies the complex regimen. And I'll be discussing on the first metformin, SGLT2, and DPP4 triple drug combination FDC in India and the role in Indian type 2 diabetes management. It's a sponsored talk, and so I'll be discussing on that drug actually. So remogliflozin based therapy in type 2 diabetes has come a long way. And if we see the first introduction of this drug way back in May 2019, it was only remogliflozin which was launched. And then in September 2019, metformin and remogliflozin combination have surfaced. And in December 2020, we have the remogliflozin and DP4 inhibitor, that is vildagliptin combination, which was launched. And recently there was a combination or triple drug combination of metformin, SGLT2 and DP4 inhibitor, that is metformin, remogliflozin and vildagliptin. And I'll talk what is the rationality of that triple drug combination and how that is going to change the clinical scenario or how we are going to treat. So the SGLT2 based regimen have already taken its importance, and we all know that how SGLT2 inhibitor have climbed the steps of AD or ESD or AC or ESI RSSDI guideline, and how they have come from the lower level to almost to the first or the second level in the management of type 2 diabetes. And the combination with metformin has been widely accepted, and combination therapy with SGLT2 inhibitor as initial treatment for type 2 diabetes, there was a good systematic review and meta-analysis was there. FDA says SGLT2 metformin combo can be used right away, and even as the first line therapy, we can start with an SGLT2 and metformin. And I'm not going into details of that, the advantages of SGLT2 inhibitors in terms of the cardiorenal benefits and how there is a competition between metformin or SGLT2 to hold back the first position.
Nirav,
Yes, sir.
there is some server's problem.
Okay. So is my slide visible?
No, it's not visible.
Okay.
Sambit,
Okay.
you have to reshare the slides.
Right. Now it's visible, sir?
Yeah, it's visible. Please go ahead.
Okay. Okay. Right. So sorry for that technical glitch. And we all know the combination of SGLT2 and DP4 inhibitor had come a long way, and now we are very widely using this combination, and it's an attractive treatment option for combination therapy. So early triple drug therapy has clearly shown that we are actually reducing the time in bringing the A1C to the normal level. And once we are reducing fast from the very beginning, then probably we are bringing not only the HbA1c faster, but we are able to maintain that HbA1c for a prolonged period of time. And this study has shown the triple combination could reduce the A1c within the first six months, and then it can be maintained even for 24 months of period. The metformin, SGLT2 and DP4, it has got wide clinical benefit. We know the advantages of metformin. It's the first line agent still now across all the guidelines. High efficacy, less safety issues, or it's highly safe, and there are CV mortality reduction has also been shown in earlier trials. SGLT2 inhibitor is the drug of choice at the current scenario, and it has got insulin independent action, weight and BP reduction. It has got many cardiorenal benefits. I think it has been discussed in the NUCD in the previous sessions. Low hypoglycemic risk is another advantages to SGLT2 inhibitors. DPP4 inhibitor, it's a glucose-dependent insulin secretion, desirable safety profile, and it's almost neutral. It's weight neutral. There is no hypoglycemia, reduces the glycemic variability, basically a very safe drug. So if we are combining these three good drugs, then probably we are going to have more advantages in managing patients with type 2 diabetes. So a fixed dose combination of metformin, SGLT2 inhibitor like remogliflozin or a DP4 inhibitor like vildagliptin was contemplated as potential solution for Indian type 2 diabetes patients. So keeping that in mind, Glenmark has come out with a combination of metformin, SGLT2 inhibitor, remogliflozin, and vildagliptin in the recent past. That's in September 2021. It was approved and was launched. So clinical development of first in India, the SGLT2 based triple drug FDC. So if we can quote one study of this combination, it's the Forever phase 3 study where there is a FDC of remogliflozin, vildagliptin for efficacy and tolerability was studied. They've done a randomized control trial, and remogliflozin plus vildagliptin FDC with metformin was used, and the concealment was, it's a double-blind, double-dummy study where it was directly compared with metformin with remogliflozin vildagliptin FDC versus metformin plus empalina FDC combination. There were two parallel groups, and it was multicentric, almost 23 city sites across India, and they've evaluated the efficacy and safety. And the best part is that it was done all in Indian patients, so we are more concerned about the use in our patients. So the study design, there was a run-in period of almost 2 weeks, and the inclusion criteria were adult with type 2 diabetes with poor glycemic control on metformin between the age group of 18 to 65 years, who were on stable doses of metformin for the last 8 weeks of more than 1500 milligram of metformin with an A1C of 8 to 11% were recruited. And after the initial run-in of 2 weeks, they were randomized to 3 arms. One is metformin was continued. The other arm, it was remogliflozin plus vildagliptin 50 milligram twice a day was added to the metformin. And in the other arm, it was empalina combination, which was added to metformin. And the study lasted for almost 4 months, and then there was a follow-up of 2 weeks period after the end of the study. Total 647 people were screened, and finally 400 were passed, and then they have divided equally between the empalina group and the removilda group, and they were randomized 200 on each arm, and the protocol population was almost 176 and 180 in each arm, and the safety population were 200 in each arm, which was studied. So at the baseline, the empalina group and the removilda group were exactly matched. There was no much differences. Just to show that the baseline A1C in both the arms were almost 9.3%. Baseline fasting was almost like 165, and PP was almost like 240 milligram per deciliter. And after introduction of empalina in the one arm and the removilda in the other arm, what they found was that they tried to see at week 6, week 12, and week 16, and they could find that mean adjusted change from baseline to in A1C in both the arms were almost similar. It was non-inferior. You can see at week 6, week 12, and week 16, almost the reduction is similar, though numerically we can tell it's better with remo vilda, but we cannot comment because it has only proven the non-inferiority in both the arms. Similarly, the progression of change in mean adjusted A1C was almost similar, with 1.46 reduction with removilda and 1.38 with empalina combination. Mean adjusted change from baseline in fasting plasma glucose was almost similar between empalina group versus removilda group. The postprandial blood glucose control was almost similar between the two groups. It was significantly lower from the baseline, but it was comparable in both the arms. And the mean change in body weight was almost similar. So at the end of 12 weeks, at the end of 16 weeks, the empalina group could reduce 1.56 kg with 1.27 kg in the removilda group, which was almost similar, but it was significant from the baseline, the reduction. Mean adjusted change from baseline in blood pressure, there was good reduction in the systolic blood pressure, almost like 1.6 millimeter to 2.2 millimeter mercury. Diastolic blood pressure was also, there was a minimal reduction. Now, we are more concerned about adverse events, and what they found was that the drug-related adverse event was almost comparable between the two groups. That means the adverse event with empalina was almost comparable to removilda, and adverse event of interest was also similar to the both the groups. And the adverse event which were concerned adverse event like genital mycotic infection, urinary tract infection, hypoglycemia, and genital pruritus, if we dissect that, then we can see that the hypoglycemia is almost similar. Urinary tract infection was not increased. Vulvovaginitis, the incidences were almost similar between the two groups. So coming to role of triple drug FDC in management of Indian type 2 diabetes. So why are we concerned about a drug which combines metformin, SGLT2 and DPP4 inhibitor? What advantages it's going to offer? If we can group that, we can group that in A, B, C, D, E basically. A is good glycemic control. We know that the three drugs can reduce the A1C significantly. B is beta cell preservation, because all the three drugs are actually beta cell protective, or they act independent of beta cell. Clinical inertia and complication. In India, managing a diabetes always lands up with inertia, and a FDC or a fixed dose combination with multiple drugs is the need of the hour, because that improves the compliance and also reduces the inertia. Diligence towards treatment or the adherence is important, because it's a single pill. Ease and economy of therapy is also there, because we are combining in remogliflozin, which is a cheaper SGLT2, and at the same time we are combining with vildagliptin generic version, which is also cheaper, and metformin is obviously a cheaper drug. So it adds to the pocket of the patient also. So tackling pathophysiology in an effective manner, we know the famous ominous octet by Defronzo, that diabetes is produced by almost 8 defects in the body, starting from alpha cell, beta cell, the hepatic glucose output, the fat cells, the decrease in the glucose uptake, the neurotransmitter dysfunction, increase in the glucose absorption in the kidneys, and decrease in the incretin effect. And to obtain a early glycemic control is important, and prolonged glycemic control is very important. And we need to address all the pathophysiological mechanism in a very effective manner, and that will add to the betterment of the patient. So multiple agents are therefore required for addressing the various arms of this ominous octet. Combination therapy, other multiple benefits. We have early attainment of target, improvement of glycemic control, reduces the complication, delayed disease progression, and better compliance with FDC, which I had already discussed. And this slide is quite interesting, because this actually compares all the drugs which are currently available, like metformin, SU, TZD, DP4, SGLT2, GLP-1, and insulin, according to their efficacy, hypoglycemia, body weight reduction, safety and tolerability, cost of therapy, CV benefits. And we all know these effects, like we know about the advantages of metformin, SU, TZD, DP4, SGLT2, GLP-1, or insulin. I'm not going details of that. I'm concentrating on the advantages of combining these three drugs. So our basic principle is that we must add more of these green buttons or the yellow buttons, and try to avoid the red buttons. Red buttons are actually the bad thing for a particular drug. Like for metformin, almost everything is green, because it's highly efficacious. Hypoglycemia is not there, weight reduction is there, safety is good, cost of therapy is low, and CV benefit is there. DPP4 and SGLT2 inhibitor, we have discussed about the advantages. The only concern was probably the red button was high cost. DPP4, the premium or the other brands are high cost. SGLT2 inhibitor is also a cost of therapy. But if you are combining a remogliflozin with a generic vildagliptin, I think that red buttons also becomes green buttons, and that makes it more advantageous. So similarly, the AAC 2020 guidelines have also placed the role of metformin, and the next only is SGLT2 inhibitor and or the GLP-1, and then the DP4 inhibitor. And if you're combining these three drugs, addressing the ominous octet in a comprehensive manner, I think nothing good like that. So what about the triple drug? Has that been approved in any other country, yes, the US FDA has approved the triple drug combination of Boehringer Ingelheim, the Trizad, which is a combination of EMPA, Lina, and Metformin. And the FDA has also approved the triple drug combination of dapagliflozin, saxagliptin, and metformin. So on that basis only, the metformin, remogliflozin, and the DPP4 inhibitor is also a good proposition, and it has somehow come into reality with the FDC of metformin, remogliflozin, and vildagliptin. So efficacy-wise, holistic management is that significant and durable glycemic control, cardio-hepatorenal protective beta cell preservation is there, safety, non-overlapping toxicity, and we also know that if we are combining an SGLT2 and DP4, probably the GMI or genital mycotic infection incidences will go down. Obviously, the advantages of CV, weight, and hypoglycemia is there with the combination. Clinical practice consideration, there is no drug-drug interaction, can be orally administered. Metformin as first-line therapy, and it's cost-effective also. So coming to the last slide, the conclusion of the FOREVER study, triple drug therapy of metformin, remogliflozin, and vildagliptin was observed to provide early and consistent glycemic reduction. Significant extra glycemic effects of weight, blood pressure reduction offer benefit beyond glycemic control. Triple therapy is not observed to be associated with any additional safety risk and offers low hypoglycemia risk. All the findings have been found to be comparable because they have taken a comparison with empagliflozin and linagliptin also, and they didn't find any, or it was non-inferior in comparison to metformin, empagliflozin, and linagliptin in glycemic reduction. So with that, I'll end my talk. Thank you for the patient hearing.